Hey, and good morning, everyone. I am your host, Joe Bosch. I'm here with my esteemed colleague, Dr. Samir Patel,
Yep.
perfusionist and physician extraordinaire. We are here for PerfWeb 112, and we're going to be talking about three things today. One is going to be goal directed perfusion, the other is going to be
ECMOs.
albumin
Yeah.
in cardiac surgery, and the third is going to be fluid uh,
Overload.
management
Mhm.
during ECMO action, specifically, I guess, fluid overload during ECMO therapy, and why that's such a problem, how it happens, why it happens, and what we have historically done and what we probably should do. But first, let's just get started on these opening remarks that I always have to make. Contact us at perfusioneducation.com. Crawl bar all across the bottom that you see there comes up and down throughout the course of the show, and you can use that to reach us. It would be appreciated. It's a small thing for you, but it's a huge thing for me to give us those. Yes, uh, give us those. Sorry, give us those likes and shares and follows and all whatever the thing is that you do in whatever platform you happen to be using. If you don't mind, it would be most appreciated, and it really does help us a lot. The MediWeb app, for those of you who don't have it, it is an app that I feel covers everything that a perfusionist, ECMO specialist, or even critical care management practitioners, CRNAs, anesthesia, pretty much anybody in the critical care unit or in surgery can use. It has a variety of features. The full app that you see displayed there has perfusion aspects, ECMO aspects, hemodynamics, clinical calculators, and if you see in the bottom left, it has an IV rate and dose calculator, and that is a really cool feature. It's a standalone app as well. This one, the full app, is $2.99. The standalone app right there that you see is 99 cents, and you can get them on the Google Play Store or the Apple App Store, whichever you prefer. We do our podcasts. We have dropped, I think, a few more, and I'm going to ask David to bring up that MediWeb page that we have. But these podcasts you'll see are on all of the platforms, any podcast platform that you choose to use. And I know that Vivian Moreno has been prolific in her vitals and vibes. I think
Yeah.
you've done several
Yeah.
programs or dropped Vicky Carlisle at the bedside. Samir's is paging Dr. Samir, and Becky Bolkovac has dropped one, and we are still in the process of refining the perfusion in jeopardy. Of these podcasts, the perfusion in jeopardy is going to be an ABCP uh, category one credit program. If we don't do it that way, it can be a category three, certainly just on its own merit.
Hmm.
But I really would like to get at least a portion of them. And it's going to be a lot of fun. We're setting it up kind of in the way that Jeopardy was run. And it's going to be very educational with board questions, science questions, perfusion questions, ECMO questions, a whole cornucopia, if you don't mind my saying, of different uh, categories. So
Hmm.
I think it's going to be a whole lot of fun. What are your, we've sort of played with it a little bit. We're having trouble with the ringing in.
I feel like it's just small stuff. The ringing in thing, I mean, we kind of didn't use actual real buzzers. We just kind of used like cheap little Amazon ones that we had
Yes,
gotten.
and they
So
did not work well at all,
they did not
and it
work well.
disrupted, I think,
It did.
the
I
thing.
think once we get a proper buzzer and we work through just a few of those little software glitches that we had, I think would be ready.
I think so too.
Yeah.
It's going to take me about a month. I have to request the credits a month in advance. So we
Mhm.
could technically do really a couple of programs and just do them as category 3. And I just think they're going to be fun in their own.
Yeah.
That people
I
can
mean, the
go
dry
back and
run was fun. It
and they
just
can
was,
watch them at any time they
yeah.
want to, right? And the
Yeah.
category 3s are really good. I mean, for those of you who don't realize this, so I do want to go over this with the audience. For those of you who may not quite understand how the CEU requirements
Mm.
actually
Even
work.
I don't know how that works.
Yeah, so I'm gonna
Curious. I'm always curious.
I'm fixing to tell you.
Yeah.
So we need 45 total CEUs if you're perfusion
Mhm.
every 3 years.
Okay.
Okay, you're on everybody's on a cycle. You have odd numbers, even numbers, and so forth.
Okay.
You have cycle 1, 2, and 3, and so you need 45 credits in your cycle, your 3-year cycle.
Mhm.
15 of those credits must be category 1.
Okay.
The remaining 30
Mhm.
can be category 2 or category 3.
And what are the difference between the categories?
So that's a good question, and I don't necessarily know I can answer exactly what category 2 is, but category 3 is essentially programs that have already been run. You don't watch them live, but you watch the educational program,
Okay.
journal articles,
Okay.
things like that. So
Okay.
any educational program
Mhm.
that the board, the American board, ABCP, approves as what would be a category 3
Sure.
classification.
Okay.
So it has to be germane to perfusion, basically.
Okay.
Okay, but not entirely. It can be. You could actually do it probably on learning about mitral valve surgery from a surgeon's perspective. I think that would still count as category 3. But I guess if you're a purist, it has to be perfusion related. But I'm
Sure.
not exactly sure how the board falls down on that.
Right.
They would have to review that on their own when you submit all your educational
Okay.
things. But 15 have to be category 1.
Okay.
Category 1, 5 of the 15 must be live, meaning you have to be online right now watching this program
Mhm.
in order for it to count as one of those 5 live, I call it live,
Right.
that you must have.
Right. Okay.
The other 10 category 1
Mhm.
can be if you're looking at category 1 SDCE. So I have to have a list of programs
Mhm.
that are submitted to the board
Okay.
and approved by them as SDCE, which is self-directed continuing education, category 1.
Okay.
Now, you can have all 45 live
Mhm.
if that's what you want to do.
Sure. Sure.
So you go to some conferences, like, for example, what used to be the New Orleans conference. We never had 45, but there are some conferences like Sanibel, for example. I'll
Mhm.
use them as an example,
Mhm.
though I don't like them and whatever.
Yeah.
I think some of the
They are, I think, the largest now, though, aren't they?
yeah, I think they are,
Comcast,
but
yeah. Like
how do
3
you
days
do
or
how do you do 45 category 1 CEUs really? I mean some of the stuff that gets approved for them for that program are it's nonsense. Now they may have some good talks. I can't say every one of their lectures are bad. They're not all
Mhm.
bad. They have some good topics and some good talks, but they don't have 45 category 1 CEU, but they get approved for 45. So you could go to one conference, basically go to the beach, go to a couple of sign in the morning, go to a couple of lectures here or there that you really want to listen to, and enjoy the vacation, and basically get all of your credits for the entire year from that period, and then you don't have to think about it anymore.
Right.
I've just gone the opposite direction.
Sure.
I've said, you know what? Hospitals are pulling back on travel. They're pulling back on reimbursement for CEUs. Let me try to make this where we're doing a live program in a pleasant setting that's visually appealing, and has value and are good lectures, good content, bring in excellent speakers like yourself, Vicky Carlisle when she does lectures, some of our other guest speakers, Dr. Navarre, Tabby, of course, when she comes and lectures, Deb Adams has lectured, Ann Gretcho has lectured, Dr. Matoyer's lecture. We've had Dr. Patel. I mean, we've had, and then of course we're also doing the ECMO course. And for those of you who haven't considered that ECMO course, it is, and we've had some issues too with people saying, well, why did I pay $600 for the ECMO course if it's included in my unlimited plan with PerfWeb? Well, I don't know why you paid that, because it clearly has a place there that says, I am an unlimited PerfWeb member. You click that and it's free, because free, to me, unlimited means unlimited.
Exactly.
And that's another thing that I think that we do that people don't necessarily always give us credit for is we have an unlimited plan. Unlimited means unlimited, but you talk to a lot you look at a lot of other programs, well, it's unlimited, but this is extra.
Right.
Okay, there is no extra. If you're an unlimited member, it's included. And if you look at the registration, the last one on the didactic section says PerfWeb Unlimited member. Click that one. You won't pay the $600. And if you know it's included, why are you giving me your credit card? I shouldn't reimburse any of you. I should just keep the money because of your dumbness. But I am honest, and everybody gets their money back.
Joe.
But if you're not an unlimited member, it would make more sense to become an unlimited member. Instead of spending $600, you'll spend $450. That makes more sense. Okay, so think about it, my fellow colleagues, who I love dearly, but do some really dumb stuff. With all of that said, our first lecture, we'll go ahead and jump into it, is goal-directed perfusion in cardiac surgery. Okay, so goal-directed perfusion sounds very lofty, but what does that really mean? What are the goals? I mean, the goals could be a whole variety of things. Like sometimes I go to work and I just think my goal today is to not kill the patient. That's a goal.
I feel that should be goal number one.
Goal number one, yeah. Goal number two is, apart from just not flat out killing the patient, how about if I do everything I can to make sure the brain gets enough oxygen so they don't come out a vegetable. They're still living, but they're dead because their brain is dead. So the whole body's dead or just the brain is dead. I'm going to try to avoid that. How about I don't want them to come out and have to be on dialysis? Well, that's a goal. There's another goal. Okay.
Let's give them some good brain, good kidneys. I like good goals.
How about if what if I consider my goal to be I'm going to bring the patient out without being 5 liters fluid overloaded. I could make that a goal. The question is, what are the goals? So I guess I'm going to punt this over to you for the sake of this discussion. What are your goals?
So obviously you have the greater goals, which are some of the ones you just mentioned.
Don't kill the patient.
Don't kill the
greater
patient.
Goal. Yeah.
Let's not kill the brain. Let's not hurt the kidneys.
Yeah.
As much as possible, as little as possible, I should say.
Yeah.
We're going to hurt the kidneys regardless of what we do. To some degree.
We're going to hurt everything.
We're going to hurt everything. So let's try to minimize said hurt. Then I think you have the case-specific goals, depending on the type of patient that you're dealing with. If you're dealing with a CKD patient, then you want to definitely watch your fluid management. It's going to be important because they may not be able to get rid of said fluid after the case.
Yeah.
If you have a diabetic patient, you may want to keep an eye on the glucose levels while the whole thing is going on. I know
a little tighter.
I know anesthesia is supposed to do that too. It's not really our responsibility, but
well,
we're also supposed to.
No, we are supposed to. I'm going to show you. I'm going to show you. I'm going to show you a little graphic that I made, so you'll see that.
So it's all what I'm getting at is all fun and games until something goes wrong. Then they're going to blame us. We're going to blame them. You know how that game goes.
Yes.
You know what I mean? So. I feel you have your case-specific goals, your overall goals, and you need to probably evaluate each of these before each case. And if you do that, it would help you, probably function a bit better in the case.
So, taking that a next step, how many perfusionists do you think go review the labs and look to see what the patient's albumin level was on admission, or as close to then the surgery
Okay.
date, if they were in the hospital, as possible.
So I don't know how many do that. I can tell you this much. I was trained to do that. Where I went to school, which was UT, we are taught to look at the albumin level ahead of time. It's something that,
Well, I have to compliment them on that.
yeah, it's we were taught
That
look
must have
at
come
it.
from Rick, because it didn't come from Igor. He doesn't know what albumin is.
No comment. No comment. But yeah, we've had that talk before. But no, it's I don't think it came from either Rick either. I feel like it came from individual perfusionists, because obviously each one of them practices differently, and depending on who's precepting you on the day, you're kind of gonna go under them. But they
Yes.
all, except for Igor, I didn't pump many cases with him, and Rick
It's because
also.
he doesn't pump cases. He doesn't know how.
Okay, we're not gonna go controversial in this episode.
I'm not. It's a stating fact.
Okay. So yeah, I was taught, look at it. If it's 2.5, give it. Even though Igor was never a fan of giving it. That I will say, because he owns that. I don't agree with that. I've told you that. You know what I mean?
But yet, it's a controversial. We're going to get into albumin next. But
my whole thing is, if it's already low, then how can you not?
But we're going to get
we'll
going to
get
into
to
that,
that.
because we actually have an albumin talk along with
we
everything
do.
else we're
We
doing
do.
today. So, okay, so that's one of your goals. So really reviewing the labs.
Yes.
Do we check, for example, during the case, do we check albumins on pump?
No.
Or do we just assume we're okay?
We assume we're okay.
Okay.
Because
Do we normally check lactates on pump?
no.
But
We do at other places.
We just
There's machines that can do it. The machines we use require different cartridges, obviously. You know this. And we don't use those cartridges. We don't use the 4s.
Yeah.
While on pump, we use the 8s.
Yeah.
For the iStats. The GEM is capable of checking the lactates.
But do we?
No. No.
Okay. Should we?
Absolutely. And again, we as a student, we did.
Yeah.
Both.
Yeah.
We
Do
did albums.
do we measure expired from the oxygenator essentially our oxygenator end tidal CO2?
No. Because
Do we know what our CO2 production is?
No.
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 So that's another
I don't know.
issue. Yeah, it's really interesting when you really start getting into this goal-directed perfusion, how many different things that we could be looking at and checking that we don't, that are readily available to us.
Right.
But we don't do it for a whole, I think, variety of reasons. Anyway, so the core challenge is a macro hemodynamic stability versus microcirculatory hypoperfusion. It's very easy, and I can give you a really good illustration of this. I did a case the other day, and actually it was Logan's senior case.
Oh, his last one?
His last one, yeah,
Nice.
his senior case, and I got to be his senior final case evaluator, which I was really glad. And he did a great job. I'll tell you right
I
now,
was about to say
he
God
did.
help him.
No, he did a fantastic job.
Great.
But
He did a good job in my cases too.
I was concerned from the very get-go that the pressure didn't look right. Something wasn't right.
What do you mean it didn't look right?
The
Can you
pressure just
elaborate a little
waveform
more?
didn't look right.
Okay,
The arterial
okay,
pressure
I see
waveform.
what you're saying.
And I
Okay.
was like, I don't really trust this. I don't trust this. I'm not trusting this. But it sort of just got
Were you not trusting the art
ignored.
line, or
I
what
was
were
not
you-
trusting the art line. I was
Okay.
not trusting the arterial line pressure that I
Okay.
was seeing.
Okay.
Anyway, we went on bypass, and man, we struggled and struggled and struggled with, okay, we're now giving Neo, at a stick at a time.
Okay.
Okay, that's too much. We got to switch to something else.
Okay.
So we switched to norepi. Norepi, we're giving more and more. They're running a norepi drip. They're up to 10 mics a minute, 12 mics a minute. with norepi. And for those of you who may not know this, but norepinephrine, sustained norepinephrine above 18 mics a minute is a independent predictor of mortality.
Okay.
So we're pretty high up.
Mm-hmm.
Usually 4 to 8 should be more than enough
Absolutely.
of norepi.
Yeah.
But with that said, we're giving more and more of it, and we come off bypass, and somewhere along the way of this procedure, before we actually came off bypass, as things were wrapping up, the surgeon, Dr. Patel, decided, yeah, I'm going to stick a femoral arterial line in. Just screw this. He put a femoral arterial line in. What a difference. Now, anesthesia argued the mean's not that different. It's only 10. But here's the difference. The systolic blood pressure on the radial was 75.
Okay.
It was 127 on the femoral.
That's a big difference.
It's a big difference.
It's a big difference.
So we're perfusing the entirety of that case at a macro hemodynamic condition, or using that as our metric. What did we do throughout? This patient did great, surprisingly enough. No issues.
Great.
But what did we do at the microcirculatory level? That much unnecessary, in my view. Pressors.
And pressure.
How much did that contribute to hypoperfusion?
Right.
At the microvascular level.
Right.
And I think this is where we are really not normally considering. And a lot of this is lactate level. A lot of this is measuring that end-tidal CO2 coming out of our oxygenator. And I have some stuff on that to explain that a little bit better, but has to do with, cellular respiration and what you're basically expelling through the oxygenator.
Sure.
But we're really living, we historically, I think, as perfusionists, function in the macrocirculatory world, because we just don't really see, it's harder to see the microvascular level without doing a lot of different.
I feel there's other indicators, though, that yes, we're not measuring lactate, but we are measuring bicarb and base excess.
This is true.
So
this is true.
If you know how to pay attention to your bicarb and base excess.
You know where this gets confusing?
Where?
This particular patient, the surgeon wanted CVVH throughout the procedure.
Oh, okay. That's where it'll get confusing. I see what you're saying.
Now that gets double confusing.
Yeah, that's double confusing, yeah.
But I think ultimately that's what saved us.
Yeah.
That's why this patient did so well.
Yeah.
Okay?
Yeah, exactly.
I think it would have been a totally different picture, especially if you don't have access to the type of fluids you need to do it. CVVH using a fluid, normal saline, even half normal saline that you're loading with bicarb and dealing with hypernatremia and trying to balance that and your bicarb up and down is a nightmare.
Yesterday, by the way.
She's very smart.
Dude, she is genius, especially with physiology and stuff like this.
Well, she's got.
We talked about this bicarb.
She's postdoctoral on her on physiology.
Exactly. So
on renal.
Obviously, she's teaching me stuff. I'm like,
Me
I don't
too.
know it to that level, but it's the chloride, Joe. Apparently, that's the problem, according to Tabby. I was like, oh, okay. With bicarb, and
that's true too.
It messes up your anion. It creates an anion gap acidosis. That's the reason we have to put bicarb. She explained this whole thing to me nicely, and it was a great conversation.
She's incredible with that.
She's really smart.
She is. I agree with you 100%. She's way smarter than me. But there is a hidden epidemic. Now, there is a 30% incidence of AKI in postoperative cardiac surgery patients, but we have to really consider this number. That does not mean that we do. So renal impairment following cardiac surgery, in my view, is still a big problem that should not continue to be. But AKI is not ARF. They are two completely different things. Now, it may make a difference long-term for this patient, may make a difference. But I feel sometimes when we look at these numbers and we go, there's a 30% incidence of AKI. Oh my God, what are we doing? 30% of our patients have acute kidney injury. Well, yeah, that is true. But what is the clinical significance of that? I think it's questionable. I think some patients are going to transition from AKI to an acute renal failure situation requiring dialysis. That probably is still too high in cardiac surgery, but there still is a high incidence of some level of injury. And some of that is going to be associated with the materials that we use, the loss of loss of pulsatile, of physiologic pulsatile flow, hemodilution, DO2 decrease. I mean, look at the DO2I. Our floor, some people say 270, some people say 280, some people say 320.
Yeah.
All of them are low.
Yeah, all of them are low.
All of them
Yeah,
are
they're all
low.
Yeah.
If mine is that
Yeah,
low
that's
right now, I'm
terrible.
in trouble.
Yeah.
Okay.
Even 320 is low.
Right. So low oxygen delivery is a primary independent predictor of AKI during CPB, which can be caused by a whole cornucopia of reasons. It can be hypoperfusion, low flow. It can be over vasoconstriction and diverting blood away from the kidneys. It can be hypotension, like vasoplegia, where you don't have a capillary opening pressure and your kidneys aren't being perfused. It could be from hemodilution. It can be inflammatory in nature. A whole bunch of different things can cause this problem that cause essentially a microcirculatory derangement of perfusion, microcirculatory perfusion derangement. So we're treating the circuit sometimes and these big pressures that we look at, but we're really not dealing with the organ at a microvascular level. That's my opinion.
Yeah, right.
And then the flaws in the formulas. Well, you see the dude on the left, okay, that's me. All right. I'm probably not going to need quite as high a flow as the person on the far right, younger person, healthy, higher metabolism, more musculature versus fat. Now, the dude in the middle, I'm not trying to fat shame. I'm not trying to fat shame. But if you just go by BSA on that patient, you are going to end up overloading that patient severely because there's no other way to get the flows that you're going to calculate out. So we have to deal with this. Old, frail, very little musculature left, their flow requirements are going to be lower. The dude in the middle is going to be much lower than their calculated flow. And ultimately, we still have to get the operation done.
Yeah.
So if you're trying to flow 6 liters on that dude, the heart's never going to be completely empty because we have limitations.
Yeah.
And then they can't see, and then they're angry, and then they're angry at you, and you're trying to so we can't rely on just raw numbers. We have to really look at the patient. That's another question I have for you.
Okay.
How many times you go in the operating room and they're doing the TEE and they're going, man, this heart's empty. This heart's they're dry.
Yeah.
And you walk over to the shins and you push and your finger goes in past your first joint.
The third spaced all their
Yeah, no, this patient's not dry.
No, they're not dry. They're just
Okay.
It's just not in the intravascular compartment.
It's just not where we want it to be.
It's not where we want it to be.
Okay. And so that's another thing. Do we really examine our patients when they come in the room?
No.
No, generally not. Do we look at their color, their skin
no.
turgor? Do we really take a lot of things into consideration? I try to, but I don't do it every time. I try to. I just don't do it every day, but I do
don't
try.
every case. But if I can, then I do. I do pay attention to the labs. That's just the doctor in me. I can't get away from that.
Yes.
I tell myself the story with the labs, but do I actually examine the patient? Not always. But I do try to look at their feet. I do.
Yeah.
If I can.
Yeah. We should.
We should.
We should. But anyway, hemodilution, really the bottom line here, is a huge problem, and one size fits all. The takeaway message of this slide is that you cannot just go by a formula. The formula has to have adjustments, modifiers to it in order to provide appropriate perfusion to the patient. Now, there's nothing wrong with luxurious flow if you can afford it, but you shouldn't be adding volume for luxurious flow if you don't need it, because that creates its own set of problems. So we have to look at these patients and really take into consideration, what is this person's true metabolic need? Because I can tell you the dude in the middle's belly does not need much blood flow, right in this, I'll just point to it here, right in this area. Not a lot of blood flow required from here to here, okay, in this section. Nor back here.
Yeah, there you go.
Yeah, or here,
Or here.
where the moobs are.
No, or the second chin down there.
Yeah, or here. Yeah, or here. Okay, so traditionally we go by weight-based BSA. Our target is a flow calculated off BSA. We are generally reactive and generalized in our approach, and we do intermittent blood gases. In goal-directed perfusion, depending on, again, what your goals are, and these goals, I mean, everybody can have their own goals, but you want real-time metabolic demand variations in your perfusion, in what your minimum perfusion flow should be. You should have dynamic deliveries of DO2 and measuring your VCO2 and your cardiac index, proactive and individualized, as far as what does this patient need, not what do the numbers say that a patient needs. And then it would be really nice if we could have truly simplified, continuous inline parameters and feedback of what we are doing. We've tried this with the CDI.
Oh, yeah.
We've tried this with a variety of different devices. I know we have continuous SVO2 and hemoglobin monitoring. I think the Essence has that.
Essence has more, apparently. It can do almost like CDI, can't it?
No,
Not
it can't do
quite
CDI.
Okay,
no,
can't go quite a CDI.
it can do saturation and
CDI
hemoglobin.
was never accurate, though.
No, it really isn't. And then that's part of the problem.
Calibrate it on every blood gas.
Yes,
Like,
it
so
would
what's
be,
the point at that point?
Correct.
Like,
It would be very nice to have an actual real-time, continuous inline monitoring. Here's the fundamental issue. The fundamental issue is that perfusion is not selling heart-lung machines. Probably makes money. Selling oxygenators and things like that probably makes some money. But the amount of money that it makes is grossly inadequate for the amount of money needed to be spent for true R&D in cardiopulmonary.
Okay.
And so I think that as the government continues to chip away at reimbursements, the cause effect of that is that, unlike, let's say, from the 1990s, 1980s probably to the early 2000s, when we saw dramatic changes in how perfusion systems were being developed, there has been almost no true change in what we're using, how we're using it, but especially what we're using, except for a much better heart-lung machine itself and the informatics that go with it, which is, good. But basically, our technology hasn't changed in 20 years.
Which is a long time.
Long time.
Yeah, it's a long time.
Yeah. So, but if there's no money, you can't do it. Where's the money? The money is in developing a TAVR. Right?
Yeah, absolutely.
They'll spend a fortune doing that because there's a fortune to be made.
Exactly.
But companies can't afford to spend. The company's in business to make money.
Yeah.
And so what's the benefit of developing some incremental thing that some people may or may not use? Some people may or may not feel it's necessary.
Right.
If you work in a place that's in a community-based hospital somewhere in middle America and you're doing 200 hearts a year, 300 hearts a year, you do blue plate specials almost exclusively. Anything that's really bad, you send out someplace else. You really don't have those same challenges. And all of your patients do well, and you've got great reputation and so forth and a very successful practice. What's your incentive to change?
Exactly.
So I think that ultimately is the problem. But these things would make our lives and would probably benefit a very small percentage of patients, but it would have profound impact on that very small percentage of patients.
Sure.
So redefining the target, the goal-directed perfusion trifecta, you have cardiac index, you have CO2 production. This is what I was talking about, which is something that's kind of coming up and people are talking about it, and it makes sense. I don't think there's an easy way to do it without involving anesthesia, because you need their end-tidal CO2 machine. Maybe that'd be nice if we had our own and we could actually measure it and not worry about, are we going to obstruct our outlet, because you don't want to do that. I mean, I think there are still some concerns and technologically having to do this the right way, but it does sound like a very interesting concept when you're evaluating cellular respiration, to see what our end-tidal CO2 is. It's a metric that can be added to everything else that we do to tell us that we're doing really good. And then, of course, you have oxygen delivery, DO2, DO2I, all leading to basically evaluating this fundamental thing, which is literally at the microcirculatory level. There is a critical threshold. I told you that in this particular slide, by this particular author, it's at 270 as your minimum. Again, I've seen 280 and I've seen as high as 320, but you're doing great. This is luxurious flow, but as your flow continues to go down, you reach a critical threshold, and at that point, you are grossly hypoperfusing the patient, and this is your area of greatest risk for tissue hypoperfusion and AKI. The kidneys are extremely sensitive to hypoperfusion. If you look at the PO2 of the kidney in the glomerulus, it's down at 25, PO2 of 25 millimeters of mercury, right? It's very, very low. So any decrease in DO2 to the kidney has profound impact. And unlike the brain, which is a huge consumer of the highest consumer, right, of oxygen, but the brain has this remarkable ability to take the last mole of oxygen remaining and screw everybody else. So the brain, surprisingly enough, as long as you have flow, can operate in a much lower oxygen tension state for a longer period of time than the kidneys actually can.
Right.
And we see that with our ECMO patients when we're trying to do ventilatory rest settings. We will accept a saturation of 78%, okay, which is damn near venous saturation, right? And the brain does just fine with that, but every single one of those patients, at least the ones that I've been involved with, I would say, maybe I can't say all, but a huge percentage of those patients that we did that with went on CRRT and ultimately dialysis post-procedure.
Right.
So I saw that as a very high incidence of new dialysis requirement in those patients, but yet the brains did fine. So that's kind of an interesting phenomenon.
Oh, yeah. The kidneys are the givers, and the brain's always the taker, right? Like,
So here you see this scale, DO2 delivery, and what your metabolic demand is with your CO2 content. And it is an early warning system. CO2 production is highly sensitive and is a real-time indicator of anaerobic metabolism at the cellular level. And that can be due to shunting from one place or another. So you may not know exactly where the problem is, but it will be an early warning that something is going on somewhere.
Right.
And I think that's very interesting, and maybe something that we should be doing more of. When you take a look at the goals, you have DO2I monitoring it, is providing the adequate flow and O2 delivery, whether it be through increased hemoglobin by using hemoconcentration, using blood transfusion, though that comes with its own set of problems. Still, you're damned if you do, damned if you don't. You have to have hemoglobin to compensate for the inability to flow more. So all of these variables interact with each other. Take a look at the VCO2 and then look at your central venous saturations and your CO2 production. All of these things are there to basically look at three things to evaluate how you are perfusing the entire organism. And because that's what we're always looking at is an entire organism.
Right.
We can't measure any individual organ unless you're, maybe you can, maybe with lactates in the liver or something like that. But
Right.
generally our patients are not coming in with liver problems.
Right.
And then defending the kidneys, there's multiple randomized controlled trials confirm, and I'll show you those at the end, that maintaining DO2I above individualized critical threshold directly prevents renal tissue hypoxia. Here you can see in the incidence of postoperative AKI much higher with traditional CPB, where we're just going with a number based on the BSA, and this is where you're measuring more of the things from the dashboard that I just showed you, and in goal-directed perfusion, and there's a reduction. And part of that really is, I think, the DO2I issue. I think that we have historically been under-perfusing a lot of patients prior to this new concept of DO2I being something we normally look at on a daily basis. I mean, 20 years ago, I didn't even think about it.
Right.
I just didn't, it wasn't even, like, am I flowing enough? I think so.
Yeah.
Yeah, it never even gave that consideration. So
Sure.
this is kind of new,
Yeah.
a new technique that I think has been beneficial for us as perfusionists. And then if you look here, protecting the microcirculation, individually optimized hemodynamic therapy drastically reduces overall complication rates, and the result is faster extubation times and significantly shortened length of stays in the intensive care unit. So goal-directed therapy, or goal-directed perfusion rather, has overall, when you look at the meta-analyses, benefited by reducing the length of stay, time on the ventilator, and all of that kind of stuff, as you can see here. I'm going to skip pediatric. I don't do pediatric, though we are going to do a pediatric program. Yes, CD4. Oh, that's you. Oh, thank you.
Yeah, no problem.
And then transfusion strategy, the fact is, like I said, damned if you do, damned if you don't, but, it has to be part of our tool in our tool chest, so to speak. If you need hemoglobin, you need hemoglobin. If your hemoglobin is 6 or 7 and you have a patient who is 6'2", weighs 220 pounds, and is not just a big fat slob, but is really somewhat, active and muscular, there's no way you can let their hemoglobin get down that low. No way.
God.
And that might not be only, just remember something that
if it was at 8.
yeah, but just exactly, but just remember something that anemia is not only caused by disease states. You bring somebody in the hospital, and there's a whole lot of things that can happen. You could lose blood, and unintentionally, and you're now anemic. So you can't just say we're not going to use blood. I don't want to use blood, but you have to use blood.
Yeah.
Now they have this, PBM thing, which I think was a lot of bullshit. I saw that a lot over the years. Perfusionists were saying, I'm in charge of our PBM at the hospital. I'm going to decide. Ty Walker, that was his name. You probably never knew Ty Walker. Oh my God, this dude was such a goofball. Jesus, Lord have mercy. I don't even know if the guy's still alive. If he's not alive, I certainly don't mean to insult somebody that's not with us anymore, but He just thought that perfusionists were going to dictate transfusion in hospitals. I mean, it was just insane. It's individualized. You have to look at the patient. You can't have these ideas that we're not going to transfuse until the hemoglobin falls below 7.
Yeah.
That's absurd.
Yeah, that is absurd.
Okay.
Yeah.
It's just insane.
Yeah, I've never been a fan of that.
I've seen 6.
Yeah.
Okay. I mean, yeah, you can get away with that with somebody who's 40 years old and otherwise healthy. You can't get away with that with a 70 kilo, 75-year-old grandmom.
No.
Okay.
Or a child.
Which is only 5 years from my age now, which is really concerning to me.
Yeah.
So yeah, I don't even talk about pediatrics.
I'm
but
just saying you can't.
You can't get away with that. So this whole idea is kind of ridiculous. I think you transfuse when you need to transfuse.
Yeah.
It's individualized on a particular case on a particular day. I don't care what the data says. I just frankly don't. You can take a law of averages all you want. You're looking at the patient in front of you. You know if they need blood. If they need blood, give them the blood.
Yeah.
And then there's, of course, a real cost to tissue hyperperfusion, especially over a long pump run. And the longer the pump run, the more opportunity there is for that. And it's the old, iceberg approach. Your problems all lie way down here where you really can't see them, and they reveal themselves as you move on and on down the course of the patient once they've left our care. Differential cost analysis, U.S. markets, you can see here that there's substantial savings if you can prevent AKI, and the same applies in the UK, and the numbers are fairly dramatic. It's a lot of money per procedure. So ultimately, if we do continuous metabolic monitoring, eliminating tissue hyperperfusion drastically reduces AKI and complications, shortens the ICU stay, and lowers and hospital stay, even time to extubation, all of those things, lowers hospital costs, and you do this, the clinical economic flywheel is superior in patient outcomes and health of the facilities that we're trying to operate in to keep the hospitals open and not make them go bankrupt and the system go bankrupt by just doing some fundamental things with what our goal-directed perfusion is. Now, again, going right back to this conversation, I don't know exactly what are all the best goals. I don't think any of us do. I don't think we've figured that out. No. I think DO2I is important. I think COP, or measuring albumin levels and keeping albumin between above 3.5 up to 5 is beneficial. I think aggressive use of ultrafiltration when needed is very beneficial. I feel that using CVVH on bypass for the removal of pro-inflammatory mediators is critically important. It should be done more commonly using the right fluid to do that, vis-a-vis Duosol or Prispicade or the next stage fluid. I mean, there's so many of them out there. And tailoring which fluid you're going to use for your particular patient. I think better thermal management, better flow management, better pressure monitoring, hemodynamic monitoring continues to be a bad problem in the operating room, which it just shouldn't be after all these years. It's the same problem we had in 1977 when I first started in this industry. So I'm like, why are we still having the same problem we had in 1977 in 2026? It doesn't make any sense to me. So ultimately, your practice, you as the clinician, as the provider, has to decide what are the best goals. What do you believe being the best goals? I've given you the list of mine, what I just rattled off. Those are what's important to me. Look at the patient when they come in the operating room. Check and see if they are tissue, if they're edematous or not. Look at the echo and see what the heart looks like. Does it look stunned? Is it from ischemia? Is it from TNF alpha, where you can maybe mitigate that? What is the operation you're going to be doing? If it's a valve, mitral especially, I know I'm going to have a lot of volume. So I'm gonna consider that when I decide, do I need to put blood in this pump or don't I need to put blood in this pump? How much volume am I gonna have? What am I gonna need to come off with? Is this gonna improve to where I'm gonna need a lot less? Can I make an effective change here? My goal, one of my goals, with the things that I just mentioned, one of my other goals is to only have 1 unit of cell saver, no more than 1 unit of cell saver, and it doesn't matter if it's a full unit. I do not want any more than 1 unit of cell saver having to give back to that patient. I want all of this blood back in that patient.
Yeah.
So I come off bypass very light. Now, not light and tight, but I will calculate my SVR. There's another one of my goals. I want to keep my SVR between 800 and 1200, and I want it 1200 when I'm ready to come off bypass, because I know it's going to start coming down, and that gives me an optimal vascular resistance in order to fill the tank. It's not dilated, it's not overly constricted, and I'm able to better feel for how this patient is going to look as we transition off bypass. But all of this is pointless if I don't have good hemodynamic monitoring.
Yeah.
So here again, we just keep going in this loop, right?
Yep.
And then the new mandates for goal-directed perfusion. This is out of 2024 with the Europeans and with AMSECT. GDP is goal-directed perfusion, no longer an academic concept. Multidisciplinary teams must integrate these algorithms into daily practice to meet modern benchmarks. The only thing I'll say about that is having a multidisciplinary team is usually a recipe for disaster, because everybody thinks their way is the right way, and you're trying to do this interdisciplinary thing. And I fight with anesthesia almost every day. They fight with me almost every day. Everybody fights with each other. So you know what? Do what you think is best for the patient, and overcome what other people are doing that you know is wrong. I do that sometimes, and they do it to me, and we go back and forth. It's ridiculous.
I was about to go there. I was like, I'm pretty sure they think you're wrong too.
They do, but I'm not. Okay, implementation, the multidisciplinary triad. So this is where we do have to work together, and I think this is correct.
Yeah.
These are the people, look, these are the players in the room that are basically having the highest level of impact on the patient sitting in the middle. There's no question about it.
No, absolutely.
So goal-directed perfusion is no longer an optional upgrade. It is definitively recognized standard of care for protecting the microcirculation and preserving patient futures. And there are my academic references. I'll open this up to any discussions you may have. I'll go with you since you're here in front of me. What are your thoughts?
I mean, yeah, I agree with just about everything you said. Pretty much all of it. I feel that you do, every individual perfusionist does need to come up with a list of the things that they think are important for them to conduct in the case for the patient. It does need to be patient tailored. Obviously, I had kind of alluded to that at the beginning, only because the comorbidities, the age, the size, as you alluded to, there's each patient's different.
Yeah, what is their basal metabolic rate?
Exactly. So you need to, if you could spend even 10 minutes, before a case, if you have that 10 minutes, obviously sometimes you don't, and figure some of these things out, I feel it would help. Now, can we calculate
you
the
have that-
VCO2? Probably not, because like you said,
No,
it's
we
not
can.
ideal. We can. We have to get
We can run
anesthesia
a
involved.
line
Yeah.
to their end tidal CO2, but
Yeah.
that's going to require cooperation, and
Exactly.
they're going to be like, what are you doing that for? That doesn't make, and then you start getting into this whole big argument, and then somebody's going to do something stupid, like put some kind of cap on it and run the line because, well, it's mixing with air, and that's giving me a skewed result, and they're going to pressurize the exhaust port of their oxygenator. Air is going to go flying into the patient, and then you're going to have a catastrophe. So wouldn't it be nice if they had some way of actually developing a system that would work, that we could measure that? There's an idea for industry out there. Maybe it wouldn't cost a whole lot of money to modify the oxygenator so you could actually hook something up to it, or develop a little mini one for the pump. I mean, you got the Essence pump, Levanova. how about putting that in there? How about putting an end tidal CO2 that can connect directly to your oxygenator? That'd be revolutionary. And it seems to me, like I said, I had never really contemplated doing that. But when
No.
I read a little bit more about CO2 production, it makes sense.
It does.
Physiologically, it makes sense.
Physiologically,
and
it
it's
makes
something
sense.
we can easily look at.
I mean, physiologically, it's like you said, it is the indicator of demand, right?
Yeah.
So it makes sense because the two parts of
And
our
you're going
supply
to
and
see
demand.
that before you're going to see the lactate go up.
Exactly. And we're so keen on looking at the supply now because DO2I has really caught on and taken on a life of its own in
Yes.
the last 15 years or so, like you've said. You know?
Yeah.
But nobody's looking
It's
at
even
the
less
demand.
than that.
It's probably less than that, yeah. But
It's less
nobody's
than the
looking
past
at the other
15 years.
side. Nobody's looking at the demand side, you know?
Yeah.
I mean, we look at SVO2. It's not that we don't look at nothing, okay? We're not
But
flying
that can
blind.
but that can be wrong.
It can be wrong, but at least it's something, I'm saying.
Because if you're shunting,
then it's going to be
your
that-
SVO2 looks great.
It looks great, right? It's abnormally high. And you're like, oh, it's 85. I'm doing great.
Yeah. So, but your CO2 is not going to do that.
No, yeah.
That's going to still go up.
Exactly.
And
So
that's why I think it's such an important indicator.
I agree with you. You know,
I don't know who
I
came up
think-
with it. Somebody came up with it. I don't know. But I can't remember what
I don't know, Joe,
article
maybe-
was first written on that.
maybe
But
in 10
for
years,
perfusion, but that
it'll
was
be
smart.
the standard for
I'll
demand.
be gone. I'll be dead.
You won't be dead.
I'm not going to be doing this.
I'm sure. I hope you wouldn't be doing this.
So do the patients.
No, I'm hoping for your sake, not for the patient's sake. You need to not be doing this in 10 years, Joe. There is a certain age where you have to draw the line. I feel you're already 42 years in. I feel like that
46.
Line, 40,
Don't take anything from me.
46. So that line you've already stepped past the line.
Yeah.
It's not that you haven't.
I just want to work until I'm done 50.
That's fine.
I want to be able to say I did this
Hey,
for 50
don't-
years.
Don't let me. I enjoy working with you, so I'll take what I can get from you.
I am pretty fun in the OR.
Oh, you're all kinds of fun. I love being with you. in the OR.
Sometimes.
I get kind of freaked out at times of where how you pump because you've been pumping for so long and we pump so differently. I'm eyes on the pump, your eyes everywhere but the pump. But you do. But guys, he's not doing anything crazy. I say this because he's
it's okay.
very comfortable in the OR.
It's okay.
Which is
It's okay.
46 years in the making.
Like I said, you know what? I haven't outright. I just haven't executed anyone yet, so
yeah,
that's good.
no. So I make it sound worse than it is. It's just
Back in the old days when I was
he
when
scares
we
the shit
used,
out of me, is what I'm saying.
when we were using bubble oxygenators and
Yeah.
that kind of thing. There was when they went to because I train on a Travenol bag.
Oh God.
I know.
We read about those.
Yeah.
we don't. I've
Yeah.
never seen one.
And then when we went to the
They
hard,
teach it to us in the
Yeah.
history portion.
I know. And then we went to the hard shell. I think the first hard shell that I ever used was the Harvey H1000. And then it was the Shiley S100. And then there was the Bentley. Bentley had one. It was a Boss 10, and you could change your PO2 by blending air on the top of the device, if I remember correctly. It was really crazy.
You're very
But
old. You're
there
very
was a
old.
s-
You're
yeah.
just showing your age right now.
But there
This
was
is
a
happening.
saying that when it came to pumping air, there are those of us that have and those of us that will. Now I never did, but I got but it was not uncommon. They used to
No.
have it was so bad. I mean,
No, yeah.
actually it was so not uncommon. This is a true story. They used to have AMSECT had a psychiatrist on where you could call anytime, day or night, like on call for always.
For what? Like, I mean, I know we work in a high stress
because
field.
because no, I mean the suicide rates in
And
perfusion.
there's that. Yeah,
I mean,
yeah.
but they would. I mean, pumping air was not that. It wasn't common, but like it happened,
Yeah, sure.
and your career's over, your life is over, you're devastated. You just executed somebody, not deliberately, but that's basic. But you feel that way. There was literally a hotline that you could call to get a psychiatrist on the phone. I mean, that's not joke.
No, yeah.
And there were. I mean, look, I can tell you that it was. I have personal knowledge of 3 perfusionists that I knew well in the course of my early career that killed themselves in various ways
Wow.
over this job.
Wow.
hmm
I know of one. I don't know him personally, but
hmm
he was a
No, I knew
UC.
them personally,
Okay, yeah, that's what I mean. Yeah.
worked with them
Wow.
3 times. That's how pervasive it was at one point in time in this industry. It has changed dramatically from then.
That's because
Dramatically.
the pumps do a good job of protecting us from ourselves
Absolutely.
nowadays.
Absolutely. No
Yeah.
question about it. I
Yeah.
think that one of the most profound improvements in perfusion from when I started to today is the safety.
Sure. The
Now,
bubble and level sensors and stuff like
all
that.
kinds of
Oh,
stuff,
oh yeah, it
automatic
does have a lot of stuff.
you name
Even
it.
the design.
But even the transition from bubble oxygenator, open arterial reservoir to
Hollow fiber.
microporous hollow fiber,
Yeah.
from roller pump to centrifugal pump, all of these things have made a
Yeah.
huge difference. But you can pump air so many ways that we
Yeah.
don't even really think about it. You don't even think about it anymore. I mean,
Oh.
whether it be the vent in backwards, but you know what? Every single one of our suction lines and some places only do it for the vent, but no, no. There will be a one-way pressure vacuum relief valve with a one-way
Yes.
check on every single line,
Absolutely.
because you're doing a case and they say, I got to use this one to connect. Whatever the case may be, they get it wrong themselves. I don't want any chances. If you
Yeah.
notice, every single one of our
Oh
suction
yeah, it has a
lines
one-way valve. Yeah.
that is on a roller
Every
pump.
one of them.
But
Yeah.
centrifugal pumping has also helped reduce.
Yeah.
But that's also killed people too,
Oh yeah, yeah.
right?
Yeah.
So, nothing about what we do is perfect,
No,
but
no.
having an automatic clamp really helps if you
Yeah.
lose your RPMs not to have retrograde flow. I mean,
Yeah.
there was a case, I don't know why we're changing subjects here, but where somebody had their purge line open
Oh,
on the top of the arterial line
and drain the
filter,
patient.
and exsanguinated the
Oh
patient.
my God.
There was another time where somebody was that was during the early days of centrifugal pump, and they were giving protamine, and they opened the clamp, didn't have enough forward flow. It retrograde flowed, clotted in the line, and then they turned it on and blew the clot into the aorta. That's happened before. I mean, there's all kinds of things that
Yeah,
can happen.
there's all kinds of things that can happen.
Everything. I mean, there's when you consider
No,
cardiac,
what we do is very dangerous.
it's very
It's very
dangerous.
dangerous. Yeah.
Can we take a 5-minute break? Okay, how about, is that okay with you?
Absolutely.
Let's do a 5-minute break so I can use the bathroom and grab another cup of coffee. We'll come right back to albumin and cardiac surgery.
Ooh. Go ahead. All right. Hey, everybody. We're back from the break. Joe is still maybe about 40 seconds out. You guys got me for the next 40 seconds. Huh? What do you say? It does. So yes, he told me to communicate that bathroom breaks for him. They can go a lot longer than normal. It's probably the size of his prostate. I'm just throwing that out there. Maybe he has an enlarged prostate. Has to squeeze harder. He's
Mhm. Yeah, it just all comes out in
Yeah,
aliquots now.
That's what it is.
It's just one aliquot after another aliquot.
Yeah,
Yeah. That's exactly. Okay, moving right along. Albumin and cardiac surgery. This is a very, very, very serious subject to me. And
agree.
I'm very passionate about this.
This came up because of a conversation you and I had.
It did?
Didn't it? We were talking about albumin one day.
I don't remember that.
Man, this is literally like, you need to work on your memory. This is only like 4 weeks ago, 5 weeks ago.
Yeah.
You're like, we need to do a program on albumin. Okay.
Oh, I probably did do that, yeah.
Yeah.
And I think that it is so misunderstood as far as, its value in cardiac surgery. And with, pretty much every patient, more so, however, with some patients. And there are many, many places and many clinicians that don't use it at all. They don't believe in it at all. They don't use it at all, and they believe or feel that their results are just as good as mine. And so, what really right do I have to make this argument? But again, you have to take everything in its totality, the 30,000-foot view, so to speak, and say, okay, are the cases you're doing the cases that I'm doing? How are we case matching these, right? And that's something that so many studies do not do a really good job on, especially those studies that are published in JECT or some of these other, not necessarily mainstream journals. I don't mean to dog our own journal, but they don't really do a good job of truly looking at a subject.
I find that funny because you have an episode where you spend the whole episode dogging our journal. That's besides the point. You did provide actual data, though, for dogging them.
Yes.
In that episode.
Yes.
You guys can find it. It's out there in our PerfWeb library.
Right. But a couple of things about albumin I think that are very important. Number one, there is no maximum amount of albumin you can use. There's no overdose, number one. Number two, this idea that it is so incredibly expensive, I think is a red herring. It is more expensive than saline, but if you take into consideration what excessive saline usage can do, the backside cost is much higher than the cost of using the albumin up front, in my opinion.
What is the cost? Do you know?
Yes, like $30 versus $3.
Oh God. Okay. Yeah.
But
that's
but
not a lot. But I mean, in cardiac surgery, $30 is like.
Yeah, I mean,
whisper in the wind.
even if you used 10 bottles, it's
whisper in the
still
wind.
$300.
Yeah, it's not,
right?
which is
That's
nothing.
An one oxygenator costs more than that.
Yeah, exactly.
But what does it cost to be in the? What's one day cost in the ICU?
Exactly.
What's $1,500?
Yeah, probably more.
You
if you got devices.
Yeah, if you got devices.
Yeah.
If you're on the ventilator, that's going to cost you another probably
what I mean.
$750 a day.
Exactly.
I mean, so what is cost? What does that really mean? I don't think $30 is very much money, but that's about what it is. Anyway, with that said, I think that that albumin is beneficial for a whole variety of reasons, which I will articulate here. Dismantling the expensive water myth. That albumin is nothing more than expensive water. The historic assumption, albumin is utilized solely to maintain 75 to 85% of plasma colloid pressure. Now, you cannot have, this says osmotic, which is incorrect. Colloid oncotic pressure or COP, is redundant. Colloids are oncotic. Therefore, it's just oncotic pressure, but we are used to saying COP, colloid oncotic pressure. However, it is true that albumin is 75 to 85% of your oncotic pressure, and that's why it is such a good surrogate to measuring actual COP. We used to actually measure COP, which should be about 25 to 30. Okay. The modern reality is that it is an active therapeutic protein. Recent clinical data mandates viewing albumin as a targeted intervention for vascular barrier stabilization, antioxidant defense, and nephroprotection. The clinical goal, therefore, transition from universal one-size-fits-all fluid resuscitation to goal-directed, kind of keeping that theme, albumin therapy, specifically for high-risk surgical populations, is now really more in vogue.
Sure.
Now, every single patient, if you just take every single patient, you're not going to, and you'll see that, I think, in the data moving forward, is not going to show much of an impact on the difference between saline and albumin. But if you take a subset of patients, the impact is profound, and you'll see that as I move along here. It is extremely good at maintaining your vascular integrity. The endothelial glycocalyx really does require albumin, and severe hypoalbuminemia or severe crystalloid hemodilution is very deleterious to your vascular your endothelial lining, your glycocalyx shield, and vascular leak is far more prevalent and likely to occur when you do have severe hypoalbuminemia. In fact, an albumin level below 2 is considered an independent predictor of mortality, much in the same way that you have, I think it's 28 on norepi. 28 mics per minute is,
I think it is
28 mics per minute of norepi has a 100 sustained, required sustained, has a 100% predicted mortality. Albumin below 2 is not quite that dramatic, but it is an independent indicator of mortality. But it has antioxidant capacity, barrier integrity, and metabolic transport. We need proteins for so many of our drugs. The preoperative burden, you have a normal, and then you have a 3.5 as your low normal, and then as you can see over the course of time, there's a major increase, a dramatic increase in major morbidities and mortalities, or mortality and major morbidity, I guess would be a better way to say that, when your albumin level is below that. Surgery today, a journal meta-analysis encompassing 22,000 patients, preoperative hypoalbuminemia is a robust, independent predictor of postoperative mortality and major complications. So this isn't just my opinion. This is published data. The clinical implication is that low baseline albumin causes a linear increase in surgical complications. It is a modifiable risk factor that demands targeted correction, not passive observation, or compounding the problem by giving the patient even more fluid. And this is especially prevalent in ECMO, where we're fluid resuscitating. They're getting more and more swollen, and they look worse and worse, requiring even more fluid administration. And if we don't fix that, we know from experience where that leads.
We had a patient recently, if you remember. I had called you.
Yes,
because
absolutely.
I thought the albumin was low because we were already third spacing only 25 or 30 minutes.
And it
on,
helped, didn't it?
And it helped.
Dramatically. I remember that. And you can't just give a little bit. You have to give the right amount. Measure the albumin level and treat it accordingly. It's
we were
not that
low
hard.
Too, if you remember, almost 1.5 or something. Really low.
Really low.
Like, so low that we were third spacing 15 minutes into the run.
Yes.
So I knew it was low, and I remember I called you.
Yes.
I was like,
absolutely.
Joe, I think it's super low.
And remember, it is synthesized in the liver. So if you have shock liver,
which we did,
from right heart failure, and shock liver is such a common occurrence, then you're not going to synthesize it, and you're not going to have it. So you have to
liver. Our
produce
AST, ALTs were off the charts.
Yeah, absolutely. So low albumin indicates baseline malnourishment, advanced age, and generalized systemic decline, but it can also be due to cath lab, phlebotomization from laboratory analyses, and replacement with just clear fluid and not enough time for the liver to produce sufficient albumin to get that level up. And it starts the cascade. Then we come to the operating room and it just gets even worse. The physical absence of albumin directly induces capillary leak, amplifies inflammatory cascades, and removes the renal protective buffer. So these are again, these are not my opinion. These are very much published data. Synthesis, the data confirms it is both. Even in minimally invasive TAVR procedures, the physiological deficit directly drives AKI and post-procedural infection. So albumin is very important, and I cannot say this enough, despite any article that could be written in the contrary of, I absolutely reject it. This is my opinion. I reject them completely out of hand. I don't want to hear it. There's no doubt in my mind albumin is a benefit for every patient. Not everyone needs it, but those that do cannot do without it. That is fundamentally my opinion. The vicious cycle of postoperative third spacing, decreased serum albumin, increased capillary leak, breakdown of the glycocalyc shield, tissue and interstitial edema, impaired organ perfusion because you essentially develop compartment syndrome in your organ parenchyma, and you can't feed the microcirculation, which leads to dysfunction, rapid decline in GFR as far as the kidneys are concerned, which then continues to, of course, the liver stops working as well. It decreases the albumin even more, and this just continues to go. Elevated risk of stage 2, 3 AKI and severe systemic infections is the ultimate problem. But you will get but you will also get. How many times have you seen a swollen heart?
Oh yeah,
A heart that's just swollen. You know, there's a saying, and this is a very important saying, and I heard it from somebody. I can't remember who taught me this. I wish I could because I want to give them credit for it, but I just can't remember at the moment. If it comes to me, I'll say it. But anasarca, which is when anasarca essentially means you look at somebody and they are just blown up like the Michelin Man. It's massive edema that you can see externally, right? Eyelids that look like balloons, tongue sticking out. You know, they're just swollen. Their hands are all swollen. All of that stuff. But anasarca is not just a visually displeasing finding. Okay, meaning, and what that means is that you open that person up, the bowels are edematous, the heart is edematous, the lungs are edematous, the liver is edematous, the kidneys are edematous, everything is edematous as well. And this creates, damn, that's close. Back that out just a little bit. I mean, man, you're looking at my nose hairs. Whew, nobody online needed to see that. But back that maybe when Magic comes back in, he could back that camera up a little bit. But it results in severe tissue hypoperfusion because the microcirculation is under pressure. It's collapsed, and this is really problematic.
Oh yeah. Plus, it's visually displeasing.
That's funny.
Back to point A.
Yeah, exactly. So anyway, this is a matrix here. The trial done by Pasonin et al. Population general cardiac surgery, 1,300 patients. Objective 20% albumin versus Ringer's lactate. For major complications. Findings, neutral results, no significant difference in the primary composite endpoint, 90-day death, renal replacement therapy requirement, or MI, proved safety but lacked universal efficacy. So in this study, the ALBICS study or trial did not show a benefit, but in 2025, with the same ALBICS AKA trial, with Shahibi showed that a high-risk targeted subset, 1,200 patients with pre-existing renal vulnerability and baseline GFR less than 60, objective was to check to determine the renal protection and reduction of stage 2-3 KI, and the findings were statistically significant nephroprotection. So again, if you're just going to take all comers and not subset anybody, you're going to skew the results.
Right.
But if you take a vulnerable population and you look at it, then that's different. But here's my point. Neither one of these studies, neither one, just did the simple, in my view, simple thing of measuring the damn albumin and treating the albumin to keep it normal or let it be abnormal. Why don't we just do that?
Right.
Why don't we just do a different kind of study? But they don't do that. And since I'm not a researcher, I don't do it myself. But I can certainly criticize all you people out there that do research. Do this research. I would appreciate it. And send it to me so I can read it, but I'll probably read it anyway. If you look at the kidneys, of course, we keep talking about the kidneys, but in 2022, the trial failed to show a benefit because of healthy kidneys masked the data.
Right.
By isolating patients,
they're getting rid of their volume. So.
Exactly. Statistically significant reduction in the requirement for dialysis with the albumin group when subset, and renal recovery. The albumin cohort demonstrated a demonstrable faster return to baseline creatinine levels when the albumin was treated in the subset of vulnerable patients. And we have to make sure we're clear on that. And here you basically see crystalloid strategy alone over time, gelatins and starches, and then albumin therapy. And basically what you're looking at here is your AKI risk is decreased slightly, if not, and at worst, stable, but with any other therapy, you can see that it is a higher risk. Albumin with CO2 in the prime, well, it coats the oxygenator. You can see how I prime my pump. I always put 50 grams of albumin in my prime.
Yep.
I know that my priming volume and my del nido are going to have that much of an impact on my overall albumin level of the patient. So everybody gets 50 grams of albumin. I put it in at the very end, and I chase out volume so I have very little left, and then I recirculate it within the oxygenator and the centrifugal pump, because those are going to be the two areas, the highest degree, the highest surface area of foreign contact surface area is what I'm trying to say.
Minimize.
So it coats things, helps to protect with platelet adhesion, oncotic preservation, and erythrocyte integrity. So you're not getting any, you're reducing the mechanical shear forces by having this protein versus just saline floating around, or red cells floating around essentially in saline.
Also will help you with your complement activation to some
Absolutely.
Degree,
No question.
Not a lot, but a little.
No question about it.
Nothing stops the complement.
No question about it. In 2023, we saw a crisis in fluid overload, positive fluid balance, and ECMO directly tied to mortality. This is, we understand this, we know this, but yet I've been in situations before where the intensivist is, your patient's fluid overload, but they look terrible. But no, let's not give albumin. No, I don't want to give albumin. There's really no data to support that albumin is beneficial. And that's just fundamentally untrue. It's fundamentally wrong. It's just flat out wrong. And when they don't want to give it, you know what I do?
Give it anyway.
No,
No.
you can't do that.
Document it.
No.
Document that they said no to.
No, a doctor shop.
Yeah, okay, that's fair. That's smart.
Yeah.
Yeah.
I find somebody that's going to run an order.
Yeah.
That's what I do. I'll advocate and fight. And then what I'll do is I'll wait until they go to sleep and wake them up and annoy them.
I like that.
Yeah.
I just go start talking real big talk.
Yeah.
That's what I do.
Yeah, I try reasoning with them first.
I do that too.
But when reasoning doesn't work,
yeah,
then as far as I'm concerned, warfare is the only option.
Yeah, I started
Okay.
throwing a lot of science at them. But,
Survival in ARDS highlights a strong association between targeted albumin administration and improved survival rates in VV ECMO patients suffering from ARDS, though you will hear some people argue the opposite of that. The data, the most recent data, does not support that. It supports treating albumin and coagulation mechanics. Again, in 2023, these are all very recent articles.
They really
ECMO
are.
creates severe hemodilution coagulopathy. Albumin limits this dilution, preserving native coagulation factors and circuit integrity far better than massive crystalloid infusions. These are very important concepts, I think, to discuss. And you can see here with the use of your hemodynamics using targeted albumin dosing, which means you're actually measuring it over the course of time. You can see as far as your need for vasoactive drugs or inotropy and so forth, it is improved over time when you are targeting albumin dosing, and your vasopressor dependency decreases at the same time. These are very important because vasopressors for long term can be very problematic. You occupy all of your receptors over time, you fatigue them. You need higher levels of pressors. You need to change pressors. It would be a lot better if we could treat the underlying cause as opposed to just simply treating the blood pressure itself. I don't know if you feel that way from your medical days.
Yeah, you hit it on the head on that one. I mean, it's a big deal. I feel like pressors, they're a double-edged sword, right? Like, you know, for the what you gain in pressure support, you lose in other things like kidney flow and this and that. So, especially if you're on a high dose of pressors, then if it can be fixed with something as simple as giving albumin, I'm not sure why a lot of people aren't on board with that. I mean, I know we have those docs that just do not like albumin, and like you said, they'll cite that there's no, science, and like I try to argue the science with them. I asked them, I flat out asked them, why? What science are you referring to? Why? And then I'll spit the science that I do know. And I'll say, do you have a rebuttal to what I just told you? And if not, then why can't we give this albumin?
Yeah.
And I bring up the vicious cycle. The like 5, 6, 7 slides ago, you had the vicious cycle,
Yes.
the albumin cycle. That's common knowledge, I feel. You know what I mean?
Well,
Like,
exactly, but knowledge is not always common. That's the problem.
you're right. Maybe I'm overselling it. I feel it should
No, you're
be
oversimplifying it.
I think it should be common knowledge for any ICU doctor,
Agreed.
specifically for ICU doctors.
I agree.
Because you see this on a daily basis. Okay, like I mean, I worked in an ICU for about 7 years, so I have seen this, Joe. I don't know how many times. Was I taught it in school? No, I wasn't. We're not taught like that. I had to see it. I had to do Googling. I had to research. And then I learned this vicious cycle on my own. Like, okay, because I saw it. And I see that once you're caught up in it, it's hard to get out of it. Once it starts, the progression to anasarca it can get there very quickly.
Yes.
And I don't care if you give the albumin. You sometimes just cannot stop it once it starts.
If you're going to do it, you have to use. Now, that's something that is very important to discuss. You can't just. So let's just hypothetically say, the most fluid overload patient that I ever was able to save, literally save, and this was at a facility in Louisiana that did not have renal docs at all. They refused to go there. They actually refused to go take care of the patient, and I worked with the CMO of the hospital, Dr. Barnard, who is such a nice man, just a wonderful person, and really caring doctor. I had to build my own CRRT machine and make all of the fluid myself from just a base fluid and with everything. And I did this day after day after day. But this lady was 28 liters fluid overloaded.
Oh, wow.
28 liters.
That's a lot of fluid.
Think about what that really means. Okay?
That's a lot of fluid.
And her albumin level was less than 1.
believe that.
Okay.
Especially with 28 liters.
We were in a lot of trouble.
Yeah.
And believe it or not, she survived. I mean, I can't believe she survived, but she survived. Anyway, make a long story short, my biggest fear was in adding too much albumin too fast and not being able to get the fluid that's going to come back into the vascular space and not put her into heart failure.
Exactly.
That
'Cause you
was
gotta
my
take it
biggest
out.
fear. On bypass, on heart, and with an open reservoir,
Right.
you don't have that concern.
Correct.
But for ECMO and a closed circuit, or a patient that's not on ECMO but just a closed circuit,
Correct.
both are equal as far as I'm concerned.
Right.
You run the risk of putting these people into massive heart failure, and
Absolutely.
they will die.
Yeah.
So you have to be able to get the volume out really fast. And it was so weird. This lady was so fluid overloaded, but she was so intravascularly hypovolemic. I couldn't believe it. How little volume she actually had in her vascular space.
Yeah, it's because she just, I mean, with below a 1,
It was
she has
bad. It
no
was very
oncotic
bad.
pressure whatsoever, so everything is just leaving the IV space.
It was very bad. It was
Yeah.
very, but like I said, she survived. And then I got charged, believe it or not, the nephrologist at the other hospital in town that wouldn't come over and help, filed a formal complaint with the Louisiana State Medical Board and charged me with practicing nephrology without a license. And even though I'm very much against state licensure, the state licensure, what was under our umbrella of treatments that we can do, fell both dialysis and CVVH or CRRT.
Yeah, yeah.
And it was in the Licensure Act.
Oh, no.
So when I went to the hearing, I brought that with me and said, "Why are we here? This I didn't do. I followed Dr. Barnard's orders. Now I gave him the orders to write, but he wrote them and signed them. Okay,
Well, then it becomes his, right?
they were his.
Yeah,
Right? He
yeah.
wrote them and signed them. Right?
We can throw
And-
ideas out there.
Correct. And I said, "So why am I here exactly?"
Mhm.
And they said, "Oh, hearing's over.
Yeah.
Have a good day." I was like, "Really? Really? You drugged me down here to Baton Rouge for this? It says right here I can do this."
Right.
So that's how petty some people can be. They refused to take they wouldn't transfer the patient.
Mm-hmm.
They were poor. They had no money. I did all of this for free and still got screwed. So
And,
no-
had to go to BR.
and had to go there. But it was just amazing to me, that's what I had to endure.
Wow.
And nobody, not one of them ever said. Now, Dr. Barnard did, the patient did, and some other people did, but not one of those people ever said, "It's a good save."
Sure.
They couldn't do it.
No.
They could not bring themselves to do
No.
it. They would see me in the hall and they would like walk away from me and so like I was diseased. It was really so weird, dude. Dude, I couldn't. It was bad. It was bad. Anyway, let's move on here. But that's a true story. It's a real story. It
What's
really
funny about
happened.
this story is I feel you would have been a lot more accepted had the patient had died.
Oh,
They'd be like, "Oh, look at this guy."
don't think I wasn't worried about it.
Yeah.
Don't think I wasn't worried about it, dude. Okay, let me tell you. If you think I wasn't thinking that,
Oh yeah.
but anyway, also it's important to understand. Do you know how many cc's of third spaced fluid each gram of albumin administered reclaims?
No, 50.
18.
18. Okay.
18.
Okay,
That's the
okay.
calculation.
Okay.
So for every gram of albumin, you reclaim 18 cc's of extravascular space fluid. So if you give 100 grams, which isn't hard to do, that's 1.8 liters,
Yeah.
right?
Yeah.
It's a lot of fluid,
Yeah.
right?
Wow. So that going back to the 28.
Right.
liters, how much albumin did you have to give that patient, Joe?
A lot.
A lot. I mean, we can do the math, but that's a
A
lot.
lot. But I
Yeah.
did it in little bits at a time.
Absolutely, because
I mean, it was-
because you have to pull it off at the same time.
But you couldn't pull it off too fast and that was the balancing act, because their intravascular space was so depleted,
Right.
I couldn't get fluid off.
Right.
So I would-
Well, you need something to flow through your CRT, right?
Everything,
Yeah.
yes, yes. Dude, it was crazy.
Yeah, that's
I
crazy.
remember that was a
That's
fun time. I don't know if Dr. Barnard's still alive. I should have him come do a program
That's
on that.
crazy.
Anyway, getting back, you have targeted administration and integration, high risk population, GFRs under 60, robust CPB prime to prevent platelet adhesion and reducing the activation of third or having third spacing occur, and also for inflammatory processes. So, mitigating inflammatory response syndrome, and in the CVICU requiring vasopressor weaning. Moderate and titratable, generally low risk surgical. So in the green, you just want to give it, okay?
Yeah.
General low risk surgical populations where albumin is safe but not yield a statistically significant reduction in overarching complications, reduction in overarching complications. And this is from that ALBICS data 2022. So, in that case, that's I view that as my routine case.
So like
my
what, if they
routine
have good
case,
kidneys,
everybody
then
gets
yellow?
it in the pump prime
Mhm.
because I know I'm gonna have an effect, but I don't give supplemental.
Sure.
If
Okay.
I have somebody that's in the green,
Mhm.
I'm gonna give more
Right.
as the case goes on. I'm gonna measure it more, I'm gonna treat it more. Now, I'm not gonna give it if it's already 4.5.
Right.
Right? But I'm going to give it if it's still bordering around 3 to 3.5 because I know it's only going to go down later.
Correct.
So I'm going to go ahead and give
2
them
liters into them.
right.
it's
I'm
gonna
going
go
to
down,
try
yeah.
to give them the best,
Yeah.
the best platform, the best. I'm going to give them the best underlying physiology for their transition to the CVICU. But then you want to avoid it if it's purely to replace massive hemorrhagic loss where you're losing blood. You can't just replace blood with albumin, okay? Utilization of albumin as blind universal primary fluid without tracking patient-specific renal risk
No.
is probably, not wise, though.
We do it temporarily.
There have recently been some data that is suggesting that over administration of albumin can be deleterious to the kidneys. I'm having a hard time understanding how that can be, and I was always taught, and everything that I've read
Because you're slamming the
historically
filter
has
with-
been
with
that
protein.
I don't know.
I mean,
I don't think so, but everything that I've read from years ago, from not just years ago, but within the past 20 years, but maybe 15, 20 years back, 10 to 15 years back, has been that there is no overdose of albumin. So I'm not sure where that's going to come out, but my view is that you can use albumin
I mean, the
a lot more liberally
The
than
only
we
thing I
do.
can think of is, you're slamming the glomerular basement membrane with albumin, and maybe that would damage it. But again, I don't know that. I'm not, I don't know. I don't know that much about
But
the
then
glomerulus.
if that was the case, then not giving albumin should improve renal outcomes, but it doesn't.
No.
So that doesn't make sense to me anyway.
No, the whole thing doesn't make sense because you can be dehydrated and have a higher than normal at the moment in a normal person. I'm talking about. I'm not talking about somebody sick. But if you're slightly dehydrated, you're hemoconcentrated because you just don't.
Your albumin will be artificially elevated.
It would be artificially elevated, and you're slamming your glomerular basement membrane with albumin. You're creating that exact situation on a physiologic normal, right? Like
Yes.
So I don't know. Let the researchers research, I guess.
Yes. So in the goal-directed therapy concept protocol, preoperative precision screening, again, albumin level of less than 3.5 is not desirable. GFR under 60, you should really be thinking about using more albumin. Intraoperative circuit defense it mandates the albumin integration into the CPB, coats the oxygenator, prevents platelet activation, actively defends the endothelial glycocalyx from shear stress and hemodilution, because shooting straight, really diluted blood into the glycocalyx is very deleterious. It just washes it off.
Yeah.
You really need that protein barrier. CVICU third space management, pillar 3 utilizes targeted 20% albumin in the first 24 hours to aggressively counteract capillary leak and resolve renal congestion and accelerate vasopressor weaning. Very important, though, to understand that, and I use 25% albumin, not 20% albumin. But with all of that said, I don't use 5% unless you just need volume, right? But if
On
you're trying to
ECMO,
reclaim volume,
yeah.
from that has been extravasated,
5%'s not gonna make sense.
don't use 5%, use
'cause you're adding volume
25%.
when
Right?
you
Yeah,
need
it
to
doesn't make
reclaim
sense.
volume.
Right. And it takes a lot more to get the same amount of albumin
Right.
and the same effect, right?
Yeah. Like it needs 500 ml to get 25 grams.
Exactly, but it is very important to understand you do not ever give albumin. Do not ever give albumin if you have confirmed capillary leak syndrome,
Okay, yeah.
because then you're just going to make it worse.
Yeah, exactly.
And really, if you have true capillary leak syndrome, you're probably not going to make it.
Exactly. I was just about to say they're
probably not gonna make it.
they're not gonna I was about to say what's the mortality rate at that point? What's the point?
It's really high.
Yeah.
Hypoalbuminemia is not a bystander. It is modifiable primary driver of mortality and acute kidney injury. And what is CSA?
I have no idea. I'll
I
tell
don't
you.
know.
Hold on.
Thank you. Universal application is obsolete. The era of one size fits all. Fluid management is over. We've discussed that ad nauseum.
Cardiac surgery associated.
Thank you. Yeah,
Acute kidney
injury. Okay. And beyond oncotic pressure from preserving the endothelial glycocalyx and coating CPB oxygen to prevent ECMO fluid overload, human serum albumin is highly active, organ protecting therapeutic tool. So let's use it more readily. And here are the the citations that were used for this this presentation. Okay. Questions, comments, concerns, disagreements?
I'm a avid albumin supporter. That's mine.
How are we doing on time? Good. Okay. Maybe we could just press on and end early.
Press
So-
on.
Staying with the theme, so something that I'm passionate about, something else I'm passionate about, the ECMO fluid paradox, navigating capillary leak, deresuscitation, and CRRT integration, a comprehensive analysis for early fluid balance, mortality, and extracorporeal management strategies. Fluid is simultaneously the lifeblood of the extracorporeal circuit and lethal toxin to the tissues. Extracorporeal support requires massive early volume expansion to establish flow and prevent access insufficiency. It is one of the biggest problems that we see when we initiate ECMO, especially emergently, and VA ECMO emergently, where I have no volume. I am dumping volume in to get flow.
Yep.
And this can be for a whole variety of reasons, but vasoplegia certainly is one of them, where you have no vascular tone and your tank is expanded to such a degree that it appears to be depleted. You need to expand the volume. Either you have to get vascular tone back, or you just need to add volume. But you can't get vascular tone back if you don't have flow. So you're really in a pickle here. And I think that, our initial reaction, my initial reaction is, give me saline, give me albumin, and I just start dumping it in. And because I just have to get flow.
Yeah.
We probably should more quickly say, give me some blood, check some blood quick. We probably should be saying that on our way into the hospital and saying, we're going to be putting this patient on VA, ECMO, the cath lab, get 2 units of packed cells and have them in the room, please. So at least we have that to get started with if we need it. If we don't, fine. But I'd get it there. You can always send it back to the blood bank,
Absolutely.
right?
Yeah.
So
I feel like it's always much later when they're like, oh, like you said, we just don't have it at the beginning. And then by the time we activate the MTP and we get our hands on it, it's already too late, right?
Correct.
Like,
Correct. Up to 85% of ECMO patients develop AKI compared to 30% for cardiac surgery. And this is due to ensuing fluid overload. Every 1 liter of cumulative fluid balance By 7 days, the 28-day mortality risk is increased by 11%.
Gosh,
It's a lot.
that is. That really puts your 28 liters into perspective.
Yes, it does.
The fact that she made it. God.
Correct. So you have the biomaterial interface that triggers foreign contact surface area. They've tried developing smart tubing and coatings and all of this stuff, but really at the end of the day, if you can get a good protein lining, a layer on it, a first pass albumin layer, it can help mitigate that. But of course, we don't do that with ECMO. We only have crystalloid in it.
Correct.
And that's how we prime it and get it ready. And we're in a hurry, and it's happening all fast. But it essentially creates an immune activation. You get, complement activation, the bad interleukins, whatever number they are, is IL-6, IL-8, surge of TNF alpha, tumor necrosis factor, which we see a lot in cardiac surgery, where you have a heart that is not, it's not from an MI, it just looks globally stunned. It's just the contractility is not there for some reason. It's just weak. A lot of times if you do aggressive CVVH and clear this TNF alpha, and the IL-6, IL-8, it can really make a difference. But it's very important also to recognize that when you do CVVH, you are also removing the anti-inflammatory mediators as well. So you have a balance of pro-inflammatory and anti-inflammatory mediators all present at the same time.
Correct.
And so when you're doing CVVH, you aren't only removing the evil humors, you're removing the good ones too.
Correct.
But in a disease state or an inflammatory state, your bad juju is disproportionately higher. Yeah. So you remove it at the disproportionate rate, and you reset the balance.
Right. Because
that's what you're trying to accomplish.
Right. Because it's gradient driven.
Correct. Exactly. So, very important for people to understand that. Yeah. But all of these things lead to capillary leak syndrome, and capillary leak syndrome can be moderate. It can be moderate, and in which case you can reverse that, or it can be severe, in which case your mortality rate is almost 100%. It's pretty close to 100% if it's not 100%. But you can have controlled capillary leak syndrome where it's just very moderate, and it's being caused by these inflammatory mediators that you can attenuate or mitigate, and also by treating, albumin, hemoglobin, all of these things, and improve it, and maybe the use of steroids if necessary, whatever you're going to do to treat the underlying problem. The brain hates it. The kidneys hate it. This is on the left, the kidneys, and when you have this capsule which has a lot of fluid pushing on it. I talked about compartment syndrome. This is what causes that. This is what the cause of it is. The microcirculation perfusion gets compromised, and over here on the right-hand side, you see the brain, and the same thing happens. You essentially have cerebral edema. Okay, I mean, this is what it is, and that's not good for us. Cumulative fluid balance trajectories dramatically diverge between survivors and non-survivors. This is, you can say which came first, the chicken or the egg, but I think that it's pretty obvious that if you're not managing the patient well enough to prevent this fluid overload, you continue to gain fluid balance, and you become a non-survivor versus a survivor. So the argument is, well, they went that way, that's why they're not a survivor. Well, okay, but what did we do to maybe take some of these people and move them down here as opposed to just letting them all go this direction? So it starts back here. It doesn't start here. It starts here.
I mean, any ICU clinician, they're always non-survivors until they're not. You have to make them survive by doing stuff, right? Like, that's why they're there.
Yes.
I mean...
Exactly. So in this ROSE framework, which is resuscitation, optimization, stabilization, and evacuation. You have you have salvage, volume expansion to establish reliable ECMO pump flow. We discussed this already. So this is your resuscitation phase. And then you want to optimize over time. The goal is to organ rescue, titrate of vasoactive support, and you want to be neutral on your fluid. Organ rescue, titration of vasoactive support in phase 2. Phase 3, stabilization. You have organ support, late conservative fluid management, and then you have your weaning, your evacuation, deresuscitation, organ repair, and active fluid removal. So this is where you're basically going from day one. Phase 1, phase 2, phase 3 is all about just getting this patient stable. And then at that point in time, you're already starting to deresuscitate the volume here, but now you really want to start getting volume out.
Right.
And these phases are not per day, they're just phases of the process.
Correct.
Advanced volume assessment requires overcoming ECMO-specific hemodynamic artifacts. You can go through this as far as you're using the electro. What is that thing called? What is that thing called where you use electrical impedance? Okay. And that's what we're looking at here. I don't want to spend a whole lot of time on this, but you can use various different tools, including this electrical impedance, to look at what the patient's extravascular fluid volume actually is. Right. So we're going to kind of skip over that. The ECMO PK challenge, capillary leak massively increases the volume of distribution of hydrophilic drugs. That's very important because volume of distribution for drugs is extremely important for a lot of our drugs. Exactly. And if you screw that up, your drugs aren't working correctly anymore. Exactly. Highly lipophilic drugs are sequestered and lost inside the tubing and the oxygenators. So these are very important concepts because if you saturate and you're thinking you need this level of whatever the medication may be, especially narcotics are certainly one.
I was just about to say, this almost always it's either our narcotics or it's any of our anesthetic drugs.
Yes.
those are big players on
Very
this.
much so.
Yeah.
And then you have to remember that once this becomes saturated, if you're going to keep that oxygenator on, you need to be coming down on those drugs. But what's really important is when you have to change it, you have to tell them because you're going to be giving that same amount and the patient's going to see nearly none of it because it's all going to want to stick until it becomes saturated again. Yep. Very important. Volume of distribution of medications is extreme. And third spacing has the same effect.
Oh, yeah.
If it's not a protein bound, okay, if it's not protein bound, it's out there.
It'll go, yeah.
And guess what? When you bring it all back, it's coming with it.
It is coming with it, and then you end up almost with overdose, especially if you didn't plan for it to come back.
Exactly.
And you're still giving it.
That's so important for people to understand. You know where I learned that from? I learned that from Michelle Lee.
Oh, really?
Michelle Lee, who is our clinical pharmacist, our intensive care pharmacist that does our ECMO specialist course. And that's where I learned this.
It's a very dangerous thing.
And I'd been doing it a while, and I didn't know that.
Yeah.
She taught it to me really well. Mechanical deresuscitation becomes mandatory. So basically, you see a hemoconcentrator there. But if you're going to be on ECMO, you're going to. I don't advocate for sticking a hemoconcentrator in line. I much prefer to use an actual device like a CRRT machine. If you don't have one, or no one will treat your patient that way, you have that under somebody else. Renal is controlling it. They don't want to use it, and you have to go to this. Well, then that's what you're going to have to go to.
Sure.
Okay. But it will work, and you can do it. The problem is that when you don't have a pump controlling the fluid coming out, then you can have essentially you forget to clamp it or you don't clamp it well enough. Your fluid balance is constantly varying too dramatically. It's not as controlled as you want it to be. Right. Plus, creating something where you're doing CVVH and replacing it with a fluid that you want the plasma water to look like, without pumps, you're also having a hard time doing that. Right. So you can do it, but it's very hard.
Plus, you don't have any of the safety mechanisms that
Right.
come along with the CRRT machines.
Exactly.
You know, they have their own built-in safety mechanisms because you're going to go right back into the ECMO, you know?
Yes. Well, now,
And
and this
so,
is another, yeah, exactly. And
yeah.
this is another concept. I want to get your opinion on this. So, up to 70% of patients will ultimately require some form of renal replacement therapy, CRRT,
Mhm.
for fluid overload, AKI, or
Mhm.
prevention of fluid overload.
Mhm.
My view
Mhm.
is you go on ECMO, start CRRT.
I agree.
There's like there shouldn't even be a discussion.
I
You go
agree
on
with that.
ECMO, you start CRRT, and you run it until you're whatever direction you're going to go. That's my fundamental belief. What say you?
I agree with that for the exact reason that we kind of built up to at this point is the start of ECMO. You will, if the kidneys are not injured, we will cause some degree of AKI just through the mechanical circulatory support that we're about to initiate.
Mm-hmm.
On top of that, we are about to dump in, especially again, like you said, if it's VA, we are about to dump in a lot of fluid.
Probably
Just
at
to
least
make
2 liters.
at least 2 liters, you know,
At least.
just to
Which
be
can
able
be
to.
30-40% of their
And
total
that, Joe, is if it's a good day if you're only giving 2 liters because we have 1 liter in our machine plus the maybe a liter, one more that we
well, not a
hang.
liter.
We have a little
The
less.
circuit,
No, yeah, it's a little less.
it's not that high. I mean, the oxygenator's
400,
280.
yeah,
The
lines
centrifugal
are
cone is about 80. So
500.
that's, yeah,
About
probably,
500.
yeah, probably about 500. But
Probably
the
about
tubing,
500.
I'd buy 500. It's not
Yeah.
quite a liter.
No, okay, so about 500. Plus, you're gonna, we'll drop, yeah, about almost. We hang at least. You're gonna give at least 1 liter, if not possibly two,
Mm-hmm.
at the beginning of initiation, just to maintain flow. So we already are starting off quite positive. Now, I get that we don't want to remove that volume initially, but you have to still be ready to
Mm-hmm.
at any given time because we don't know what we're dealing with.
Correct.
And we don't know hemodynamically how this patient's going to present. But we do know one thing is they don't pee a lot at the beginning.
No, they don't.
Not unless we have to supplement.
Well,
with
they're in
either
shock.
Bumex. Yeah, right.
They're in shock,
We have to make them pee by giving them Lasix, Bumex,
which is
Diarils, whatever.
nephrotoxic.
Exactly.
When you can do this.
When you can do this. So that is why I'm a full supporter of connecting it. Now, you don't have to be pulling at the beginning.
No.
Now, I'm not saying that we should have it
But
be pulled.
why not create
Exactly.
neutral true homeostasis
Exactly.
using CVVH with zero balance? We call it Z-buff. I don't care what you call it.
Yep.
But basically not removing fluid,
Exactly.
but just removing all of these evil humors. That's
Yep.
what I call it.
And
The bad juju. Why would that hurt? I don't understand the
So, let
concept of
me-
why they argue.
let me tell you why they argue, because I was them. Okay, I was on the
I'll forgive you.
I was on the other side, is when we assume either dialysis or we assume CVVH or CRRT or whatever the case, whatever modality we're using, we always assume you're going to be pulling something. We don't ever think zero balance. Initially, that's
mhm.
not the thought we have in our head. In fact, I wasn't even aware that you could zero balance at the beginning initially. And then also we think about extra circuit. You know what I mean? And the danger of you adding a piece to the extra
That
circuit.
teeny little circuit compared to this big ass
I
ECMO.
know. Again, we minimize devices as an intensivist,
And that's
to the degree of
understandable.
what you can,
And that's
You
and
know?
that I respect that.
right?
That does make sense to me.
Unless it's required.
Mhm.
So when you're saying something like, "Oh, let's just have it there in case," which now I support. So let me be clear about that. I
Mhm.
support this because now I see that we will most likely be using it at some point in time, if not at the beginning to maintain, a zero balance.
Mhm.
It just, as for an intensivist, it doesn't, that just in case, it doesn't sound like a good idea.
Mhm.
You know what I mean? Because, well, we can use it. We can attach it when we need to attach it.
Yeah.
I mean, you have an ECMO already. You can throw it on any time, right?
Mhm.
I mean, yes, you can, right?
Mhm.
And that's the thought process they have.
Mhm.
That's the thought process I had.
Mhm.
So I don't know what they're thinking, but I can tell you what I was thinking.
Yeah, and I understand that. And to me, I think 180 degrees opposite.
Mhm.
My thought is, let's start this now and prevent
Correct.
what predictably
Mhm.
I'm operating on a law of probability.
Right.
I've seen this many times. I know what's going to happen.
Right.
Now I could be wrong; it might not, but the probability is
Mhm.
very high.
Right.
So, do I do this now and prevent it in what is highly probable,
Mhm.
or do I not do it so that I don't, by some chance, put it on somebody that really didn't need it? What is my risk? What's the
Exactly.
risk of it?
No, yeah.
And though I understand you're taught in school and it's drilled in you, every device, and it's true, every device carries risk.
And you don't
I don't think there's any
introduce it if you
question
don't
about that.
need it.
Exactly.
And the quote unquote need, you know what I mean?
Correct. I do understand that.
Right.
But that's subjective.
Exactly.
Need
It
is subjective.
It is subjective.
And
It
that's
is.
where I think that people become, and we did it in Perfusion. In fact,
Oh,
I
yeah.
talked about this in one of my earlier slides about this was our old standard.
Exactly.
We did this by the numbers. We painted by
Right.
numbers.
We did.
Okay?
Like I told
But you got to
my-
change.
And like I told you, my views as I have become more educated in ECMO, and I'm hoping that I'm a good example for the way that the future physicians, and when I mean physicians, I'm more talking about ICU intensivists, will also change because now ECMO is on the rise. We are doing more and more ECMO. Intensivists are getting more exposure to ECMO. They're seeing now.
Yes.
Shit, I should have probably connected that in
Yes.
at the beginning. They're
Yes.
seeing it. You know what I mean?
Yeah, you know what
We
they're
didn't-
saying? You know what they're saying?
What are they saying?
They're saying, damn it,
Yeah.
Joe was right.
Damn it, Joe.
I should have listened to Joe.
No, I mean, again, for me, I see it all the time now. For me, I'm now sitting on the other side. I'm sitting in the seat next to the ECMO as opposed to being the doctor that's just in the room every now and then.
Mm-hmm.
So I'm getting to see in real time what this ECMO is doing.
Mm-hmm.
So my opinion has changed just due basically to the fact that I've experienced it. But they're experiencing it too now, more.
I think so.
Yeah, I mean,
And I just think we're getting better at it. The more we do it, the more experience we have.
Yeah.
I think it's making sense. So, moving on here, integrated CRT architectures eliminate secondary vascular access but introduce pressure complexities. That's a red herring. That's easily adjustable and manageable. So, this was a bigger concern with the next stage machine and still can be, but using which I just want to be clear on something. I hate Next Stage as a company. I hate Baxter Gambro equally as a company. I think all these companies suck. I just hate them. However, truly, in my opinion, you cannot compare the device complexity, reliability, manageability, and accuracy between the Baxter Gambro machine and the Next Stage machine. There's no question that the Baxter Gambro machine, Prisma Flex, Prismax, or whatever it's called, is a far better technology, technologically far better than the Next Stage.
Sure.
Now, I hate both companies equally,
Sure.
but my opinion is that widget is better.
if you had to pick one, right?
Yes.
Yeah.
Yes, I do believe that. Anyway, it's very easy to add these to the circuit. Now, there is something to take into consideration. Anytime you plug anything into your circuit, you are now risking, and actually that's something that we should talk about more probably in our ECMO courses. You have two sides of an ECMO. You have a negative side and you have a positive side.
You're right.
Okay? Never, ever, 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 ever allow anyone to touch the negative side of your circuit.
Yeah.
No matter how much they want to help by connecting this CRRT return line into your line that's going into the negative side, don't let anybody ever help you.
Yeah.
Also recommends that for ECMO specialists or nurses at the bedside managing the ECMO, that your circuit have 0 connections, open connections, stopcocks, the lower locks, whatever, on the negative or positive side.
Okay.
0.
Even on the positive side.
Even on the positive side.
Well, you want to
There was
air, you'll just lose volume.
There was a case. There was a case that I almost went to go transfer because we had that same issue with Life Flight was willing to do it, but Memorial Life Flight, Herman,
Yeah.
but your guys wouldn't go and take the patient. And I was going to go, I won't say where the hospital was, to get the patient. And it was one of our critical care practitioners that we had, relative of theirs. And ultimately, when they found out I was going to get them, that they had refused, they all of a sudden changed their mind and decided to go get the patient.
Politics.
But yeah, it just goes to show them how they are. But regardless, while they were at that other hospital, the family member noticed something and looked under the bed, and a stopcock on the positive side had opened, and there was a pond of blood, which was going to turn into a lake of blood, which was going to result in the patient dying, under the bed where you couldn't see it.
Oh.
And they just happened to be sitting in a place where they looked and could see, and pointed it out. But they ended up having to transfuse that patient. And this was a young kid who ended up getting a double lung transplant, COVID. So you really have to be careful when you go connecting things to your circuit. So going back to your argument of you don't want to start adding devices, because as you add devices, you increase risk. That is very true.
It's what you're taught. Like it's
Right.
It's ICU 101,
Yes, but at the same time, we really need this. This is the risk. We have to be aware of it. I think people need to understand that, and really understand just how much trouble you can get into if you're just not careful and planned.
Oh yeah.
Right?
Yeah.
You have to know your circuit really well. So that's really important, I think, to point out.
I didn't know they don't allow. I didn't know ELSO doesn't allow the.
No, they recommend.
Recommend. Okay.
They don't allow or disallow anything.
Yeah. Okay.
This is a recommendation.
A recommendation for their ECMO specialists.
Yes.
Not to have positive or negative openings.
Exactly. I think we went through all of this, alarms. I don't want to go through all of that again. ECMO and weaning assessment, negative balance path, achieving a negative cumulative fluid balance 24 hours prior to weaning, independently associated with a 3 times higher likelihood of first-day weaning success. I thought that was pretty interesting. That was I think, a very good point.
So 24 hours only? I guess it depends on how much fluid you're
No,
pulling
if
too,
you're
right?
if you achieve a negative cumulative fluid balance, at least 24 hours prior to weaning,
at least 24 hours.
is independently associated with a 3 times higher likelihood of first-day weaning success.
I misunderstood.
Whereas if you're fluid
you have
overloaded,
24 hours to get the fluid out. And that's
right,
crazy.
correct.
What
No,
if
you
they're-
want to be with 24 hours prior to your
gotcha.
weaning.
Yeah.
You want to make sure you're in a negative, not euvolemic, a negative fluid balance is actually preferred.
That also goes against that supports that graph you had showed us.
Yes,
at
especially
positive
the
weaning.
lungs. There's a lot of
Oh,
data.
yeah.
If you look at the data on CRRT and on ECMO, the newer ECMO data, look, the harsh reality is, especially VV, the harsh reality is drier patients actually do better.
Yeah, because they don't have anything going in their lungs or creating any pulmonary edema.
It's true. So the 4 pillars of evidence-based fluid stewardship in an ECMO circuit extrapleural patient: anticipate capillary leak syndrome. It's really important. Mitigate to the best of your ability, SIRS. Track your, what is CFB? Your fluid balance. Thank you.
Cardiac
Transition from rescue phase to stabilization, escalate evacuation quickly, more aggressively from loop diuretics to sequential nephron blockade, and seamlessly into integrated CRRT. So their preference is CRRT over diuretics.
Which
And
is, like you said,
standardized
good.
circuit connections, utilize integrated CRT to eliminate vascular access complications, guided strictly by pressure management protocols to prevent hemolysis. But that's all about the circuit design, because sometimes you have to adjust stopcocks to make the pressures work and all that kind of stuff.
You do. Those things are.
Cumulative fluid balance, CFB. Here, it's my slide, and what the hell was CFB? I should just write everything out. It'd be easier
like
if I would just write it out.
That was like your CSA.
Because now I'm supposed to, now I'm supposed to remember this shit.
Yeah.
Okay. Okay. Fluid. We've beaten like say dead horse. Drier patients do better, and that includes ECMO patients. And I'm done.
There you go.
Questions, comments, concerns.
I like today's topics. I feel like we see them a lot, especially if you do ECMO. Then you're seeing these on a regular, especially the fluid hemodynamics. They help.
Yes.
I've had to call you multiple times due to hemodynamic. I wanted your views. I oftentimes knew what I needed to do. I just need somebody to also tell me that it's a good idea.
Yeah. Well, I mean, I think that,
it's always the thing I worry the
but
most about.
and I think that's really, that's I think what is really good about our group, if I may, I'll compliment our group. I call you.
Yeah, you do.
You don't just call me.
No, yeah.
I call you.
Yeah, it goes
Dude.
both ways for sure.
What do you think? What do you think? Now I'll call Becky. I'll
Yeah.
call. I'll
Yeah.
call Kevin. I'll
Yeah.
call Mindy.
Yeah.
Min. I'll
Yeah.
call Min.
Yeah.
Min's been doing this a long time, man, and he
time,
does.
man.
Of all the people in our group,
Mhm.
between you and him
Yeah.
and Mindy,
Yeah.
dude, it's a free for all
It is.
about who gets the extra ECMO shifts.
It is,
Okay,
yeah.
y'all fight over that
We
stuff.
do.
And it's pretty remarkable to me. But you guys have a lot of experience with it, and
Yeah.
probably more contemporary experience than me. You do more of it now than I do.
Sure.
My experience is slowly becoming more historical. Now I'm still working. I still
yeah.
did do Logan's senior case with him,
You did.
and he did a better job than I would have done. He did really great. He did really good. I can't wait. He's coming back to join us.
He's really good at what he does.
No, he's really good. You know
I've
what? He's
been with him.
motivated.
I love
He's happy at work. He likes what he's
Yeah.
doing. He's really doing well. And
I had the pleasure of being on one of his cases, but he did such a good job. I didn't know what to teach him. I'm like, I
Yeah.
don't know what to tell you.
you know who else? You know who else was really good? You know who else was really good? I got to tell you, man. I mean, for someone who started out where she started out, Lindsay has really become a good little perfusionist. I'm going to tell you, man.
She's really knowledgeable.
She's not only really
She's a good
knowledgeable,
student, too.
but she's really motivated. Like
She
she's
is.
got a tremendous amount of pride. Like she
does.
really wants. What I see in her
Yeah.
is she really wants to be viewed as the best.
She was a really good student.
She-
You
I'm
have to
telling ya.
understand. Even in school, I always thought, like, she was, dude, on our first exam in school, Lindsay, I'm sorry if you don't want people to know this, but I have to throw this out there because it was a big deal. Our first exam, anatomy physiology, was our first exam ever. She beat me, dude. She got a higher score than me. I was like, oh my God. I was
know.
shocked by it. Okay,
I know.
like that's
I know.
that's crazy. Nobody. How do you beat a doctor in anatomy and physiology? Especially the first test is all basic stuff.
Yeah.
Like-
And she was an auto transfusionist,
exactly.
perfusion assistant. But man, when I worked with her, when she was a perfusion assistant, and I worked with her, dude, she was always so interested in things. I've never had some, and she never. I mean, it never annoyed me, but sometimes I just had to say, Lindsay, I got to do the case. Okay, I'll answer.
yeah,
I'll answer your questions in a minute, but I got to do the case right now. But
Good.
I loved it. I just did. I loved it. She was really good at what she did, and I'm
We have
proud of
one-
her.
We have a new auto transfusionist.
And the other thing that, yeah, exactly. Sully Beth.
Oh my
Oh, she's
gosh,
highly motivated.
dude,
I've heard nothing
so
but the
many
best about
questions.
her.
So, oh wow,
You know,
I'm impressed. But I wish I was like her. I was like, oh my god, like
and
she's
and now
gonna be
with
amazing.
NRP and stuff, and
Mhm.
even though it would be, I guess it'd be tantamount. It would be a declared like emergency type of thing, but you know, our team, the perfusion, like our group right now,
Mhm.
we've gone through some transitions.
Mhm.
We've had some people that I'm just glad they're gone.
Sure.
I mean, that's a different topic for a different day.
Sure.
But right now, God forbid, if one of us were to fall out in the middle of the procedure, they could hold it together until somebody got there.
Yeah.
And I think that means so much to me that we've built that kind of a program. I'm really
I like
excited
that
about it.
we have people that don't really complain too much, especially when you get called
Not
for something.
everyone. No, we have a few. We have
Obviously, but
we have
you
one
have
or
a healthy
two.
balance, let me say. You're always gonna have complainers. That's just the name of the game, Joe.
Yeah.
What I mean by complainers is I mean like somebody you can call even if they're not on call. You at least have a healthy number of people that would still want to help you out.
The overwhelming majority
Yes.
will do it. And actually, that is, I believe, what should be the expectation, because n- here's how I view it.
Sometimes you just need the closest guy.
Here's how I, here's how I view it. I have a skill that somebody who I never met before needs, and potentially can be the difference between them living or dying.
Like 5 minutes can.
Yeah.
Like literally 5 minutes.
So even if I'm not responsible,
Mm-hmm.
I view it as a privilege, and I think everybody should view it that
I
way.
view it that way.
Now, if the employer, on the other hand, is constantly doing that because of poor management,
That's a different story.
well, then go find another job.
Yeah, that's
okay.
different. That's different.
That's fine. Go find another
Mhm.
job. But if in our situation,
Mm-hmm.
no one is going to call you just to be mean.
No.
This is serious business.
This is.
I think that it's funny how people can be, but I just feel that if if what we do isn't bigger than that, bigger than your comfort,
Mm-hmm.
you're in the wrong industry.
Yeah. Oh, for sure.
You're just in the wrong industry. I'm
You can't-
sorry.
You can't be in acute care, and specifically hyper acute care.
Mhm.
The times where you got to run, where people are literally dying every minute that you're taking to get there.
Mhm.
Is they're dying, literally dying.
Yes. And you know
it's
what?
Not even putting it nicely. That is exactly what's happening.
Exactly.
You know what I mean?
I had it happen to me once. And let me tell you this, for those that may be listening, I'm just chewing up some time. You have to remember something about me.
Mm-hmm.
I was an employee, whether it be a group,
Mm-hmm.
like a large company, a hospital, a group of surgeons, or just a hired gun individual, right?
Yeah.
Far longer than I've been a practice owner,
Yeah,
right?
Practice owner, right?
Totally, and I think a lot of people forget that, but I actually had that happen to me one time. A person was driving down the road,
Mm-hmm.
literally passing the hospital,
Mm-hmm.
and it was a serious crisis.
Mm-hmm.
The appropriate person was on their way, but I knew where that person was, and they're not with us anymore, but they refused to go in. They said, I'm not on call, and I'm on my way home. I'm not going. Hung up.
I mean,
That person, in my opinion, shouldn't be in this industry. They do not deserve the privilege to be in this industry. That is how I feel fundamentally. Because that's happened to me, you know how many times? Like I
Yeah,
said,
yeah.
I was an employee long before
Yeah.
I've been in this position.
Yeah. Me too. I mean,
Many more years.
I mean, I think of it a couple of different ways. Number one, I've been in acute care for so long, so
and
I
you
know,
know how many other times it had happened to that person?
Never. Well, that was probably the first time.
Never.
Wow, that's rough.
Mhm.
Some people, Joe, their time is their time. They don't care. You could be literally dying. In that situation they were, and they didn't care. I mean, it just goes a lot. It's the person. It's not even their work ethic. It's the person. How much they actually care, about.
Why don't we vet that out? Why don't we not focus on that during the interview process? Because you could find that out about a person. Why don't we do some kind of a test where this is built into the test that the probability of that kind of response would be exposed somewhere in this test, and use that as a guide for hiring people into this industry?
I'll tell you why, and I'll use your own analogy. It depends where the pendulum is on if you can do that. If the pendulum's way out there and perfusionists are dime a dozen and you have your choice of the pick of the litter, then yeah, you can do that. But if the pendulum's way over here and, you don't have your choice of perfusionists, you need perfusionists to have a perfusion
We've been
company.
there.
And
We were there.
You've been there.
We
right.
were there.
Yeah,
And you know what I did? Bad hires.
Yeah, exactly, because you didn't have a choice.
Bad
You
hires.
didn't have a choice.
Several of them.
Yeah.
Yeah. Anyway, this has been one hell of a program. I thought we've sort of gone off track from
We did.
goal-directed perfusion
We
and
did.
albumin and ECMO to people.
people.
But you know what?
That's perfusion.
We're within margin of error for time to
There we
end for the
go.
board. They won't yell at me. I won't get a bad mark or a nasty gram. So thank you all very much. The next time I'm going to see you is coming up in like a couple of weeks for our didactic portion of our ECMO course. If you are going to be on that course, remember it is included in your unlimited plan. So please take advantage of it. You don't have to pay extra. It is included in your unlimited
Unless
plan.
you want to.
No, the ones that did are asking for the money back, making me do more work. I should charge them a fee
Of course they are.
for making me have to work. But with that said, so it is included. But there are rules. You'll getting those in the email. You have this is serious with the board. We have to see you. You have to be online. So please keep that in mind. This is not something you can sign up for and then not attend. All right, we can't do that. We'll lose our credentials, our credentialing from the American board, and I completely understand and respect that. You're supposed to be part of this and be learning. So keep that in mind. So, but that course is a really good course. There's a full course and there's a didactic only course. But the full course, of course, I love that, but that's limited in the number of people that we can have. The didactic only is not limited. So check it out. Go to mediweb.us. Do you have that online? Can you bring MediWeb up? You'll see it right here. I'm going to show it to you. But it's MediWeb. If you go to MediWeb, there it is right there, mediweb.us, go to Adult ECMO Specialist course. And if you want to share this with some nurses, scroll down so they can see the different courses that we have for nurses. That's the ECMO course. Can you go to MediWeb so they can see the different courses that we have? But that's the Adult ECMO course. Yeah, our CVICU course. There it is right there, CVICU Essentials. We have the CCRN prep course coming up pretty soon, Advanced Hemodynamics, Intra-aortic Balloon Pumping, and these courses are done by Vicki Carlisle, and these are all excellent courses and approved for nursing credits. So if you have nurses that are friends of yours or in the hospital, please don't hesitate to direct them to the mediweb.us site. A lot of really good stuff in there for critical care. And Perfusionist with the balloon pump would be very helpful too, because we really learn a lot about balloon pumping and how it works, because we're not trained with that anymore.
No, they teach us it in school, but it's not.
It's pretty rudimentary.
We learn more from the videos that are sent to us by the manufacturers.
Yes.
Than actually are taught by the.
But these videos are by an actual practitioner that really knows what she's talking about.
Yeah, that's better.
And can distill it down to where, it's not commercialized.
And that's good, because now I feel ABCP, specifically on our exams, now is asking more counterpulsation questions.
Yes.
Like you're actually getting balloon questions on the
Yes.
exams.
I need to make sure that Mindy,
Mhm.
our perfusion in
Jeopardy?
jeopardy, puts a lot of IABP. I know a lot about IABP, and now I
Jesus.
know you don't know as
Yeah,
much.
I don't know as much.
So I need that category. Okay.
I'm gonna make sure she has more medical questions.
Peace out, y'all.
All right, bye, you guys.
See you next week or a couple of weeks.